distinguish how the terminal branches are and how the main branches, who are paired, who are unpaired, and who are visceral and who are somatic. So now, these are the common iliacs. We talk about where they go, femoral, and now the veins. We talk about arteries of the posterior abdominal wall. Now the main veins of the posterior abdominal wall, and we had inferior vena cava, how it is formed. Two common iliacs fuse at L5, fifth lumbar vertebrae, and then they make inferior vena cava, which runs not L4. L4 is the level for artery. L5 is the level for the vein. So L5 they fuse and they make inferior vena cava, which goes up to the 8th thoracic vertebral level, T8, passes the central tendon of the diaphragm and opening into the right atrium of the heart. Is that right? Now, veins never give branches. That's the biggest misnomer with you guys. You put branches of the veins, branches of the arteries. The veins have always tributaries because arteries give branches. Veins receive blood. Veins are not distributing blood. Veins are collecting blood. So those vessels who are collecting, they are the tributaries. And now let's figure out the tributaries for the inferior vena cava. I'm talking between T8 to L5. So there we had the femoral and the external iliac and internal iliacs. So three terminal tributaries, right and left common iliac veins, median sacral vein. So that completes my three tributaries, or those who make the inferior vena cava. If someone asks you how and where inferior vena cava is made, how and where? It is made at L5 by two common iliacs and median sacral. That's the answer. Someone may ask you where the inferior vena cava commences, give its vertebral level. Commences means where it is formed. L5. So there are different ways of asking question. Try to get familiarized with these terminologies, then you will be able to go with the right options. May you know the right answer, but you don't know how to figure it out. So now the five paired somatic tributaries, reverse the name of the arteries. We had phrenics, we have lumbar, these are somatic paired. Visceral tributaries, we had paired ones, we had hepatic veins, renal vein. Now, the left renal vein is very important. Why? Have you focused in CVP? We focus a lot on left brachiocephalic. Because it was crossing, more oblique and all that. So now this left renal vein, again that important. Reason? It crosses over the aorta and it goes under the mesenteric. So that's the situation. If there is a problem, if there is a growth, if there is an aneurysm, it can compromise either of the structures. If there is an aneurysm of the aorta, it will compromise this left renal vein. And another important feature which is associated with this left renal vein, people present to you, some male present to you with infertility. Now, there is a very common disease, there is a very common problem which is known as varicocele. In Arabic you call it dawali. And what is dawali or varicocele? Is, you understand varicocele? Fine. For those, dawali is the term, they will understand it. Let them. Now, what is happening? Okay, stand and give us the answer.
When the left renal vein is compressed?
No, my dear. So stay quiet. Any other person who, I know there were so many were jumping with answers, so give me a... No, I'm not asking what happens. My question is, what is the mechanism behind? So what is the, on examination, what is your finding?
Incompetence.
You will see incompetence was on examination? the veins within the scrotum, becomes dilated. Number one, tortuous 2, and it appears, because you are not opening the scrotum and to see someone's veins, it appears as if the scrotum is full of worms. It gives you appearance of having worms. So many worms, insects within the scrotum, and that's the feeling of a testis who has varicose veins. And effect is why this person is presenting to you with infertility, because testis was sent out of the abdomen because of high temperature, and it was given an extra cover, and that cover was helpful to maintain the temperature regulation. Now once this testis is again surrounded by the dilated veins, blood has temperature, and now this testis is under temperature. So in high temperature, spermatogenesis is not possible. In high temperature, spermatogenesis is not possible. So once there is no spermatogenesis, this person will not have any kid. He will not be father. And it has been observed, of those who present with varicose veins, 40% of them, after surgery, they have the chance, their partners can become pregnant. And it has been observed. Yes?
Sir, if someone works in hot conditions, will it be harder for him to be infertile?
Yeah, that's true. I can tell you, I have done a survey, the workers in oil fields, those who are working where there is a digging and all that is happening, those who are searching, that environment is very hot. And there I have noticed in that camp, a big number of people presented with the infertility situations. And even when we excluded out, a lot of them was having azoospermia. There was no sperm. I'm not talking about spermatogenesis or failure or this and that. There was totally no sperm seen in their testicular tissue. That was quite an astonishing, and it has been famous for hot environment. Now if you notice, those who live in hot environments, look at their dressing style. They are using loose dresses. They are not wearing tight and this and that. If you see the farmers and all these people and the occupational people, they are wearing very loose sort of dresses. So that improves little bit of aeration. And there are so many other comorbids and factors which are linked. But this is a big detail, and we are not here talking about infertile issues and all that. But I mentioned that how it is related, Mohanad. If there is a question, then it was not discussed in the class. Yes, Rama. Huh? Now, if I say yes to your answer, you can say in Saudi there is a big area where there is a high temperature, so how the people are having, mashallah, so many kids and this and that. There is something called adaptation. But it is highly seen that in high temperatures, the chances of spermatogenesis are lower. How much lower? It's variable. Understand? Then you come up with a laborer who has a series of kids. If you compare it with an office worker who has only 2, so then, I will not, because it's all been recorded, we'll talk of the. So the idea is, the veins, they have tributaries, and we had terminal tributaries, and then we had somatic, visceral and all that. So we were talking about, and my objective, don't forget the objective. So bottom line is, don't forget about left renal vein. Left renal vein will be as if like you have seen the left brachiocephalic vein. Got it? It was in the labels. So left renal vein, it compresses upon, it causes a lot. And why I was talking this, the left gonadal vein is not going to the inferior vena cava. Left gonadal vein is going to the left renal vein. And this is one part, and second part, the inferior suprarenal vein also been draining into the renal vein, left renal vein. So now, There you can see, I mentioned this word. The inferior suprarenal vein is also connected, is also draining. It's not draining into inferior vena cava, it's draining to the left renal vein. You can see it. You can see the communication. And then you can see here the left gonadal vein is also draining into the renal vein. Which renal vein? Left renal vein. And the right gonadal vein, it goes to the inferior vena cava. Is that clear?
Yes.
Can superior aorta or the superior mesenteric cause aggressive drainage of the vein from the left renal vein?
No, little. What do you mean by word little drainage?
Dilation of the vein.
Siri.
Dilation.
Obviously, once there is a tumor, once there is a growth, once there is an aneurysm, it will impair. Yusuf and Umar, stop. Once there is something, it will derange, it will compress, it will cause certain effects on the neighbor, on the adjoining areas. It's always there as a rule. Clear?
Again, excuse me, what compressed the left vein? The mesenteric?
Inferior, you can see that the superior mesenteric, it crosses it over.
So,
If there is a growth, if there is something wrong, if there is aneurysm of this, or vice versa, they can hamper each other. There is a specific tumor of this area. I don't want to, make it level 2 or level 3 class. So with you guys, it's just let it be a simpler version.
but to affect the gonad also to affect the suprarenal. So it's like we have multiple.
If there is a tumor, guys, now he has poked the subject, so let me talk about it. If there is a compression onto this gonadal vein, fine, we know it. If valves become incompetent, then there is no flow of blood in the veins, agree. But valves are fine. So what other reasons? If there is a growth here, if there is a tumor here, if there is a mass here, it can compress on right, on left, so you can have maybe patient present to you with bilateral varicose veins. So that is possible. So if there is any external compression on these vessels, or look, the problem is within the wall or problem is outside the wall. Within the wall, incompetency of the valves. Outside the wall is some growth, some external pressure which is compressing upon these vessels, and that is causing the poor return or no return. So blood is bound to stay in the lower down area. Is that clear now? So the right gonadal vein to inferior vena cava and left gonadal vein to the left renal vein. So now don't ask me where are these clinical notes. I had prepared that, and if you guys need, I will pass it on and you can read through them. Now we learn about the bones, the muscles, the nerves, arteries and veins. Now all these structures, this is just a repetition of the same. I don't know why there are 2 slides of the same type. Now, what is happening? As I said in the beginning, all these structures are retroperitoneal. So they are covered by the parietal layer of the peritoneum, and it's all behind that. It's not inside. That's why when we operate on kidney for stone disease, for having certain abscesses and all that, we try to go from the back or we try to go laterally. We go anteriorly to the kidney only for when we are dealing with cancers. Well, in this era now, we have only 2 to 3% of open surgeries for the area. We all have 98, 97% all endoscopic surgeries, all laser surgeries for this renal area, renal block. But 2 to 3% of the cases where there are certain severe issues, then we need to intervene by open surgery. So that era of making big cuts is gone. So now, for the cancers, why we go anteriorly? Because we need to have, because these cancers sometimes they are so wild and we have to look for so many things. That's why we approach anteriorly. Otherwise, we always go from laterally or from posteriorly. Is that clear? So they all are behind the retroperitoneum or the peritoneum, parietal peritoneum. Now these are the muscles and all that. Now this is important. What has happened here? Now I heard an answer hernia. What do you think? Inguinal hernia. Inguinal abscess. What else? Now I'll ask you a question. How you differentiate between a hernia or anything else?
Ask him to wait.
One by one. Okay, Mati.
It depends on the thing that you need.
Kenan. Jafar. When I say this, scoop, it means close.
Cavity.
Cavity to cavity, don't give me the definition. Ali, want to say something?
Using other techniques such as MRI.
Say loud, he's saying about color. No, Nasu.
This is when you compress
CT or MRI, my dear, you are a very expensive doctor. Every patient, they will not come to you. Yes, Nasir. Guys, this is an important question. Amu, just listen to me. So, Faji. Saleh. No, they have said we will not do a CT scan. What we do? Say it. Fahad. No. No X-ray.
Symptoms?
Now done, or is there any answer left? Very simple test. Okay. Who said cough? Give a big hand to him. The answer is definite, not like causes this and that. Remember, for your lifetime, if you are distinguishing hernia from anything else, ask the person to cough. And after coughing, observe that part. Don't observe his coughing. Observe the part which you are examining. If there is an impulse, it means this is a hernia. If there is no impulse, it's not hernia. Then it is something else. Now you can palpate, you can feel for the fluid, you can go for the color, you can ask an X-ray, X-ray will not give you anything. You go for a CT, you go for an MR, you put a needle, but please don't put a needle, you may put a needle in aneurysm, see what happens then. So don't go with this habit of putting needle everywhere, otherwise you will cry one day with big tears. So always ask the person to cough, and it's a very commonly done mistake. Patient like this, and it's all under the skin. Nobody come with this picture. The person will come with some swelling in the inguinal region. You didn't understand yet? Do you have a question? So, cough impulse. If you cough, that part which is hernia, that will show an impulse. That will show a flicker. A cough impulse. So the pressure will be increased. So now what is the treatment? What has happened? Now what has happened? Nasu, you're talking, now tell me what has happened here. Why this has happened? Yes? My dear, reducible, non-reducible, obstructed or any hernia.